Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
All right, welcome to the PFC podcast. We're about to hear from Dr. Sean Keenan. Sean is the head of the Prolonged Field Care Working Group. He's an ER doc, and he's currently the 10th Special Forces Group Command Surgeon. Sean's going to give us a quick intro to PFC, how this thing got started, why we're calling it PFC, and basically just present a vision for where this thing's going and what we hope to accomplish.
Sean Keenan. I'm an ER doc, I'm the 10th Group Surgeon. So what happened was, we had these case studies coming up for the SOMA conference, SAMHSA conference last December 2013. And there was just kind of this need like, hey, there's these dudes holding these patients for a long period of time. We're not really talking about that. And so SOMA basically said, I think we need to set up a working group to kind of talk about this body of knowledge that it's not necessarily new. And there's other people talking about it. So NATO had a research workshop that talked about it. The Canadians have been talking about it a couple of years, and they basically said we need to start focusing on this thing. They were calling it extended care at the time. Well, we were calling it extended care. They, during their workshop, basically came out and said, we're going to call it prolonged field care. And they put a lot of thought into that, and that's eventually what we decided to call it. So prolonged field care is basically the care beyond the planning timelines. So, for instance, you do TC3 on somebody and you go through all the stuff and you hit the end of the protocol and then you're like, all right, you back this patient out, and then you get the call and the sad face that says, hey, I need to sit on this guy for the next 6 to 8 hours. Well, then what do you do? And there's a whole, kind of body of knowledge or a need for that knowledge to try to look at how is it that I manage a critical patient in an austere environment, limited resources, and how do I go about managing that? And so prolonged field care is basically that. And, early on in the discussion, we decided it was always brief that 18 Delta can hold somebody for 72 hours. But we know that that's kind of BS, because there are some patients that you could be sitting on with a whole critical care team that's going to challenge them. You're going to run out of supplies. You're going to run out of knowledge. It's, 4 dudes working on a guy for a couple of hours. I mean, that may be exhaustive to them. And then there's some people that maybe you could hold them for 5 or 7 days. And so as much as the operational planners want to put a time on that, because that's natural for operational planning, we really kind of got away from assigning a time to it, and it's more has to do with patient condition and how do you assess that and that type of thing. And so prolonged is basically like, oh crap, I've hit the end of my algorithm, but now I need to sit on this person. And we're seeing that all over the place now. We're getting out of the the defined theaters of war, and we're going to these places, and it's the same places we've always been to. So this isn't a new body of knowledge. This is just kind of refocusing how we think about providing medical support. So everyone kind of grew up in the call a 9 line, sit on this guy for a half hour or 45 minutes, and then they're going to fly away. But now we're getting back to the UW stuff. We're getting back to going to these countries and really just hanging guys way out there. And although the risk of getting injured is a lot lower than what it was, it's still there. And guys are kind of realizing, the kind of the oh shit scenario, like, oh man, I could be, taking care of a guy who was in a rollover or got burned or had a accident at the range and got shot accidentally. And so we're trying to look at where the knowledge gaps are, and then trying to address that. And everyone's going to do it differently. Every unit is going to approach operational problems differently. And we're not talking about operational specific, but we're talking about the skills that folks need to be able to address serious, critical, or serious casualties and hold them for a long period of time. So that's kind of where the prolonged field.
Can you talk about SOMA and how you got into this with Doc Mabry and kind of his guidance on it?
Yeah, so basically, I was kind of doing my usual thing where I like talk to him, and I was kind of bitching, hey, there's not enough stuff for special forces, and you guys are talking about all this TC3 crap. We need to talk about it. And he's like, absolutely, and you need to link up with these other guys who've been talking about that. So you and trauma surgeon, basically we're presenting this, and you guys had been deployed with a lot of time on your hands as you sat and you went through all these different scenarios and said, hey, we've got a real deficit in our training and we're not really focusing on the right stuff. And so kind of this year at SOMA, there was extended care vignettes, but we were looking at a way to kind of tackle the problem, realizing that it's not that we had beat TC3 to death, but we had basically taken it from being 95% great to 97% great, but we need to focus on other stuff. And the community was saying, okay, we got this, but there's a real problem out there that we're not addressing, and that's kind of the extended care thing. So, we were kind of directed to start a working group. And going into it, as we talked about it, we kind of had all these preconceived notions about what we were going to talk about. But when we got a bunch of smart guys in the room, it quickly changed the priorities. And then we did it over 2 lunchtimes. And even the second day, we were kind of putting together the subject matter we were going to talk about 2 hours before we were talking about it because it was evolving so quickly. And then we decided, okay, there's a need for this. There was a lot of interest. We got a lot of guys' emails and stuff. But we decided we're going to go ahead and take this outside the normal decision-making process of the military. We're going to kind of use some of the models on the civilian side, which is kind of like open feedback, open discussion, kind of going wherever this thing takes us. And so we were able to kind of rapidly incorporate some stuff with technology and communications, but start gathering ideas, and we're basically letting this thing flow, brings to us. So they say, we need this, and we get a question about this. And our idea is not to set up protocols, it's not to develop guidelines, it's not to dictate somebody how to do stuff. So immediately when we were talking about this, they were saying, hey, can you refine the TMAP, so the protocols that are out there for the soft guys? Can you suggest equipment we need to buy? Can you tell us what we need to do in our training? We said, well, first we need to take a step back and figure out what we don't know, what we know, what we don't know, what equipment we have, and then kind of break it apart from there, and then try to figure out where the knowledge gaps are, because there's a lot of good stuff out there already in protocols, guidelines, the TMAPs, what guys are already training on. But we were trying to, right now, we're still in this discovery phase of trying to figure out where are the knowledge gaps, and then how can we take the 50-pound brains, how can we take that, put an operational spin on it, and then provide useful information out to the community that they can then use to modify their own training, their own education, their own protocols. And so we're not into breaking this down to a protocol. We're more in the providing the knowledge gap so that guys can be better informed, to work out their own training, stuff like that.
So SOMA has basically sponsored this effort. Give us the website, to hang products on. So with that in mind, what does success look like for this thing? Where do you see this going at the end of the day?
I'm not really sure, because a lot of times we're asking questions, but then we're figuring out a lot of the answers are already out there. And then as we start researching different issues, for instance, the fluid resuscitation stuff, we thought, man, we need to really look at fluid resuscitation. Well, it turns out the TC3 committee just did exhaustive research on that, and in fact, we got some of that information, got to look at it, and said, okay, actually they've done most of the work on this. They've got all the knowledge base. So what we're going to do is we're just going to fill in the gaps in that knowledge. So what we found out, for instance, when we're teaching the fresh whole blood transfusions, which is kind of going to be the way a lot of folks go into, and I think that's one of our main recommendations. As we were teaching this to smart medics, they already understand the technique. They understand the TMAP behind it. They understand the protocols that are out there. But then they started asking some of the hard questions. So then we were able to take those and tease out kind of the frequently asked questions when you're teaching this, and then really get into depth about some of the more esoteric issues along with it.
All right, so there was our first podcast. I know that was a little bit rough, had a few editing issues, but they're going to get better. So if you have any comments, please go to prolongedfieldcare.org and let us know what you think. And thanks for listening.